to AETCM, the emergency medicine channel. Today let us discuss about one of the important platelet disorder, that is immune thrombocytopenic purpura or ITP. Previously it was known as idiopathic thrombocytopenic purpura. When we didn't know what was the cause for the purpura or thrombocytopenia, we used to call that idiopathic. Now we know that it is immune mediated and we can call it as immune thrombocytopenia and immune thrombocytopenic purpura. Purpura is bleeding into the subcutaneous plane and that can produce red rashes all over the body. Now here in thrombocytopenia, there are different causes for thrombocytopenia. Either it can be the production can be reduced in the problem in the bone marrow, or it can destroy in the spleen when there is a massive splenomegaly, or it can be destroyed by infections like dengue, leptospira, malaria and all, or it can be antibody mediated destruction. Here the antibodies like IgG antibodies placed on the patient's cells, and it can directed against platelet membrane glycoprotein, that is GP2B3A glycoprotein. So these platelets are attached with antibodies. They will be detected as foreign body in our system, immune system, and that will be destroyed by our immune system. That is immune mediated thrombocytopenia. There is a mechanism. So basically this ITP is divided into two major classes. One is acute ITP, other one is chronic ITP. Chronic ITP we routinely see mainly in adults, mainly in women, and antibodies against GP2P and 3A. Acute ITP is mainly seen in children and rarely it can occur in adult also. Mostly it is followed by a viral exanthematous fever. That's why whenever we have a viral exanthematous fever and thrombocytopenia, some patients, you can see patients are not recovering from thrombocytopenia and they slowly develop permanent thrombocytopenia. These are triggers for acute thrombocytopenia and that leads to permanent platelet disorder and thrombocytopenia, and that leads to bleeding problems and purpuric rashes. Here it is called as, the mechanism is called as molecular mimicry. The antibodies which are produced against the organism, that they cross react with the platelets and they try to attach with the platelets, and these attached platelets will be destroyed by immune system. Now rarely you can get gestational thrombocytopenia. It can also occur in preeclampsia, HELP syndrome. All these conditions also we can get transient thrombocytopenia, or in pregnancy ITP can flare up. A patient who is having ITP who never had hospitalization or never had investigation in the past, suddenly during pregnancy when we are doing the blood routine test, we can see the patient is developing thrombocytopenia. That is called as ITP during pregnancy. There are other causes for that also, but ITP also can come into picture. Secondary ITP, it can see in patients who is having hepatitis C virus, HIV virus, SLE or CLL, lymphoma conditions. Now clinical features you can see here: small subcutaneous bleeding points, purpuric rashes all over the body. So not only in the lower limb, here the picture is in the lower limb, but you can get the lesion all over the body. That is very, very important. Extensive bleeding points all over the body, that occurs when the platelet count is less than 50,000 cubic millimeter. And if platelet count is less than 10,000, that type of patients can have spontaneous bleeding. Here less than 50,000, they are prone for purpuric rashes. That is a small petechial rashes you can see on the skin. But in a patient who is having platelet count less than 10,000, they can have significant bleeding anywhere in the body. It can be intracranial bleeding, it can be a bleeding into the eyes, it can be bleeding into the abdomen. Wherever possible, patient can have bleed. But the commonest presentation is bleeding while brushing the tooth. That is the commonest presentation of ITP. And menstrual period bleeding is very, very classical in young females. Whenever the menstrual period occurring during ITP time, patient can have extensive bleeding. Bleeding may not be controlled with routine measures, or it may be extensive. Now, purpura is seen when the blood is extravasated into the dermis, and as a result of the lesion do not blanch on the pressure. So, you can see some rashes that when we press it, it disappears, whereas in purpuric rashes produced by thrombocytopenia, they do not blanch on pressure. And one more important thing is some purpuric rashes are palpable. They are due to vasculitic lesions, but whereas in thrombocytopenic purpuras are non-palpable lesions. And you can differentiate different types of purpuras other than thrombocytopenic purpura. That purpuras are meningococcemia, DIC, erythema gangrenosum, leukocytoclastic vasculitis, henoch-Schwann purpura that especially occurs in the lower limb, polyarthritis nodosa, SLE, all these conditions you can get purpura. And purpuras which are due to vasculitis, they are actually palpable purpuras. And purpuras due to non-vasculitic condition, they are non-palpable purpuras. And in thrombocytopenia, they are non-palpable purpuras. That is very, very important. Now again, depending on the time, we can again classify ITP into newly diagnosed up to 3 months since diagnosis, persistent 3 to 12 months since diagnosis, chronic more than 12 months since diagnosis. Most of the adult patients will come under chronic purpuras, and they have chronic thrombocytopenia, chronic ITP. In diagnostic clue, you can see many patients who is having purpura can have a previous history of or recent history of fever, sepsis, DIC. All these things can be there. Because purpuras can be due to various other causes also, we have seen that, not only because of thrombocytopenia. So, fever indicates infection, sepsis, DIC. Hepatosplenomegaly indicates liver disease, hypersplenism, lymphoma. Neurological findings like neuropathy indicates TTP, HUS, and vitamin B12 deficiency, copper deficiency and all. Lymphadenopathy indicates again infections like dengue fever or any other viral fever, lymphomas, malignancies. Thrombosis, heparin-induced thrombosis, antiphospholipid syndrome, paroxysmal nocturnal hemoglobinuria, all these things can occur. So, associated symptoms are very, very important. Normally, ITP will not have any other clinical finding other than purpura. That is very, very important. When the patient is having purpura, thrombocytopenia, any of the features what is seen in the slide, then you have to go for an alternative diagnosis. Whereas in ITP, patient can have thrombocytopenia with only purpura, no other clinical features will be there. Even history of fever, if you take previous history of fever, previous history of viral infection can be there. But during the episode, most of the patients are asymptomatic. Only symptom will be purpuric rashes, bleeding tendencies. Now, if you see the peripheral smear, that is very, very important because platelet counts, when we do automated missions, we can see thrombocytopenia. But if you ask for a peripheral smear, you can see that the number of platelets can be increased. That is because the automated mission picks the clumps as single platelet, whereas in peripheral smear, when we are looking through the peripheral smear, we can individually count the numbers from the platelet clumps, so that whenever we have a thrombocytopenia in an automated mission, we have to always ask for a peripheral smear by an expert pathologist. We have to see what is the count in the peripheral smear. That will give the exact platelet count. That is very, very important in clinical practice. So, never depend only on the automated mission platelet count. Whenever we are suspecting thrombocytopenia, at least initially we have to ask for a peripheral smear, and exact count will be given by the pathologist. Other investigations like bleeding time. Normally, when the platelet counts or platelet function is deranged, you can see the bleeding time is increased. That is one of the easiest tests which can be done in all emergency room. If you are seeing purpuric rashes, look at the bleeding time. If it is prolonged, then the purpura is mostly due to platelet disorder. But nowadays, in most of the emergency room, you can get point of care missions which can pick up thrombocytopenia very early. Next is bone marrow study. That is very, very important when we are suspecting ITP. we have to rule out all other causes before making a diagnosis of ITP. So we have to rule out bone marrow infiltration, bone marrow diseases which can reduce the number of platelets. So bone marrow study is very, very important to make a proper diagnosis of ITP. If bone marrow shows increased production of platelets, young platelets are there in the bone marrow, that indicates a peripheral destruction of platelet, and the production of the platelets in the bone marrow will be increased. Other investigations like SLE can be ruled out, ANA, dsDNA. Viral markers like hepatitis B, hepatitis C markers should be done. Other viruses also should be ruled out. Leptospira, dengue, QBC for malaria, prothrombin time, INR, APTT, all these things should be done to rule out other causes, because it's a diagnosis of exclusion. You have to exclude many other diseases to make a diagnosis of immune thrombocytopenia, because nowadays in a routine clinical practice we don't have any investigation to make a diagnosis of immune thrombocytopenia. We don't have any antibody test to make a diagnosis of immune thrombocytopenia. We have to rule out all other causes to make a diagnosis of immune thrombocytopenia. So that is very, very important. Whenever we are suspecting ITP, rule out other causes before giving a diagnosis, including bone marrow to be done to make a proper diagnosis. Now, once you make a diagnosis of ITP, if the patient is in danger, bleeding tendency, or the platelets are very low, patient is acutely ill, then IVIG is the treatment of choice. 1 gram per kg, 1 to 2 days you give. That is a treatment of choice. Along with that, we can start prednisolone. It can be given 1 to 2 milligram per kg body weight, and it can be continued for 4 to 6 weeks. Then slowly taper down the dose. Like you can give 70 milligram in a 70 kg patient. Then every week it can be continued till the patient improves. Like some patients improves very fast, the platelet count will become normal in 1 or 2 weeks. Then you can taper down. Taper down means every week you can reduce 10 milligram. Like first week it will be 70, second week it will be 60, third week it will be 50, then 40, then 30, then 20, then 10, then 7.5. Then if you want, you can reduce to 7.5 milligram alternate days. It can also reduce the adverse effects of steroids. That is the advantage. But during the reduction, you have to see the platelet count also. That is very, very important. Other drugs like azathioprine and cyclophosphamide also can be given as a pulse therapy initially, and rituximab, that is CD20 monoclonal antibody, 100 milligram IV weekly can be given. So these are the routine drugs given in acute thrombocytopenia, immune thrombocytopenia. So you can give IVIG. Initially you can give, whenever patient is having flares, you can again give it. Rituximab also can be given. That's a biological monoclonal antibody. Then we can continue the patient on prednisolone. That can be started with higher dose and taper down the dose. We can also add drugs like azathioprine, 50 milligram BD initially, then slowly taper down the dose. That is very important. So we can start that also. L-Trombopag is another important drug. It improves the production of platelets from the bone marrow. So that increases the production from the bone marrow. So whenever there is a peripheral destruction, to improve the production, it can be started. L-Trombopag, 50 milligram per day. Another drug which is similar to L-Trombopag is romiplastim. So that also can be given. That is given as injections. So these two drugs can be tried if there is no response to other treatment, because these drugs are very costly, and they should be given in patients who is having no response to drugs like steroids or azathioprines. They increases the bone marrow production of platelets. Now IVIG and glucocorticoid together we can give in many patients. Either we can, in acute condition where the patient is having severe thrombocytopenia, we can give pulse therapy of methylprednisolone, that is 1 gram methylprednisolone into 3 days, or we can give a cheaper drug, that is dexamethasone, 40 milligram intravenously into 1 to 4 days. That can be given. Then along with that we can give IVIG also. Since it's an immune mediated condition, IVIG will work like steroid or better than steroid, and adverse effects are lesser than steroid. So we can give IVIG and it can be associated with your steroids. Anti-D immune globulin also can be tried in patients who is having thrombocytopenia, immune thrombocytopenia, where IVIG cannot be given, or due to some reason patient is not able to take that. Anti-D immune globulin also can be tried, but routinely we give IVIG and steroids. Then the patient will be on steroids and azathioprine, and steroids will be tapered down and stopped after some time. Azathioprine will be continued for a longer period. Whenever patient is having flares, again we can give IVIG or rituximab. That is a normal treatment plan. Now, desired platelet count is very, very important, because platelet count, whenever it is reduced, we no need to transfuse the patient, because in our body platelets live only for 7 days. Our own platelet live in our body for only for 7 days, but transfused platelet that lives in our body only for 24 hours, and sometimes it is less than 24 hours because of the immune mediated destruction. So long-term therapy, somebody is on long-term follow-up for ITP, unnecessarily transfusion is not very, very good, because it lasts only, the platelet which we transfuse lasts only for few hours. So it's a total waste of money and time. So if you want to prevent bleeding in conditions like where you want to prevent a spontaneous bleeding, you can keep the platelet count more than 10,000. And the central line insertion, you can keep it above 20,000. Anticoagulation, if you want to give for some conditions where the patient is having stroke or myocardial infarction, you have to keep around more than 50,000. Minor surgery, you keep it above 50,000. Major surgery, keep it above 1 lakh. So these are the some points where we have to treat the patient, like patient is going for a surgery, patient is going for a minor procedure, patient is going for a central line insertion, patient is having spontaneous bleeding. So all these conditions, sometimes we will have to give platelet transfusion prophylactically. Like if you are putting a central line, along with you can start the platelet transfusion and you can put the central line. That is also very, very useful. Now you should know about the platelet transfusion also. Like we have discussed about platelets in the body, how many days it will live, we already discussed. Usual dose of platelet 1 unit per 10 kg body weight is a usual dose, and it should be transfused in 5 to 10 minutes. So you should not keep platelet for a long period. You take the platelet from the blood bank, immediately you have to transfuse, otherwise it will become ineffective. And if we are having any delay in transfusion, slightly shake the bag continuously, otherwise platelet aggregation will occur. 1 unit platelet will raise the recipient platelet count to 5,000 to 7,000 only if it's a fresh patient. But a patient who is taking repeated platelet transfusion, the problem is they can develop antibodies against various types of platelets, and ultimately patient platelet, whenever transfused, immediately these platelets will be destroyed by our body. So repeated transfusion should be avoided in patients who require repeated transfusion. That is very important. If you are continuously transfusing for a small reason, then there will be large number of antibodies produced against these platelets, and whenever we transfuse next time same type of platelet, it will be immediately destroyed in the circulation. Another important this one is platelets are available as single donor and multi donor. That also we will see. Platelet transfusion is done when there is an emergency, and it is available as pooled platelets or single donor platelet. That is also very important when we are transfusing. Pooled platelet means platelets are taken from different individuals and pooled together, and we give it for a patient. Suppose the patient is having thrombocytopenia for dengue, leptospira, low platelet, you decided to transfuse, you can go for pooled platelet. That's okay, because we are giving only 1 or 2 times in a lifetime, we are giving 1 or 2 times platelet transfusion. That does not change the treatment in that patient. But whereas in ITP, these patients may require recurrent platelet transfusion. So, a single transfusion itself, we are using multiple donors, then multiple types of antibodies are produced against different types of platelets, and next time when we are transfusing, the platelet will be destroyed very fast. To avoid this condition, we always try to use single donor platelet transfusion in patients who is having ITP. But one disadvantage is this is very costly when we are comparing with a pooled platelet, but there is advantages. Antibody production can be minimized and later patient may not develop antibodies and destruction of transfused platelets. So that can be avoided. So this is the treatment for plan for ITP. Steroid IVIG, then steroid should be continued, then rituximab also can be given, TPO agonist like L-Thrombopac can be given, then splenomegaly can be considered in patients who is not responding to routine treatment, and many patients who is having chronic ITP should be continued on immunosuppressant like azathioprine. So this is the treatment plan for ITP when it becomes chronic. And another important syndrome also we'll just discuss, that is Evans syndrome. It is immune thrombocytopenia with autoimmune hemolytic anemia. So two syndromes together is called as Evans syndrome, immune thrombocytopenia with immune mediated hemolytic anemia. So this patient can have thrombocytopenia with anemia. So we have discussed about one of the important condition, that is thrombocytopenia in emergency room. Thrombocytopenia can be immune or non-immune. Now, immune is always, it's a long-term problem for the patient. Other conditions like dengue, leptospira, malaria, all are short-term problems. Long-term problem in patients who is having ITP, they have lesser bleeding events than a patient who is having acute problem. Because you can see the patient who is having ITP will not have any clinical bleeding even if the platelet counts are less than 10,000, like even some patients you can see 3,000, 4,000 and all without any bleeding chances, because all the platelets in their circulations are very young platelets. That is a reason for not bleeding in ITP. Whereas in a condition like acute problem, acute thrombocytopenia, in that patient the younger platelets are less, all the types of platelets are destroyed in periphery, whereas in ITP, newer platelets are there in circulation, older platelets are destroyed. So whatever is available in the circulation, they are all very young and very active platelets. So the bleeding tendency somehow it is very, very less in ITP. So the need of transfusion also is less in ITP, and it should be avoided as far as possible, because you know that multiple platelet transfusion produce large number of antibodies and the destruction also can be increased. And immunosuppressant is the treatment for the ITP mainly. Thank you.